Thank you again for the invitation to this wonderful meeting. It's a great gathering. I've learned a lot. I'm not sure I'm going to teach you anything new, but this is an area in evolution, so hopefully you will bear with me. These are my disclosures, but above all, I have a fantastic team, both working with the NLR registry data, which I'm going to show you, and also doing the AI work that's going to lead to the next generation of this. In reality, defining success after ACL reconstruction is not as straightforward as we as surgeons imagine. Because actually, if you stop to think, even the starting point is vague, because we can define activity levels, but actually defining the real score before a patient starts is difficult because we only meet the patient usually when they're injured. So there are a number of metrics we can look at in terms of looking at outcome here, be they patient-based, be they objective, or be they imaging. So we can argue about that, and that will lead to the evolution of what I'm going to talk about. There's also a reality which I mentioned yesterday, is that not everybody really does recover after an ACL reconstruction. The surgeon says goodbye, they go away, but whilst their ability to return to high-level function in elite sport is good, outside elite sport, it really isn't that great. And of course, there are a number of reasons why the reconstruction fails. Sometimes it's to do with the indications or the compliance of the patients. Sometimes, and quite a lot, is to do with the surgery. And Bertrand's little presentation was fantastic because we will actually be able to finally understand, if we can capture that, what the surgeon has actually done in the operation. From a research perspective, that will be amazing. And then, of course, rehabilitation is key. So can we actually predict failure? Can we sit in a room with a patient and say your chances of failing after this operation are X, even if we agree what failure is? And some groups have tried to do this. So credit to the Moon Group. Based on the Moon Group data set, if you go to this website, you can get it via the QR code or via the website, you can actually get a little calculator that will give you the risk of failure. So you enter your age, you enter your sex, whether your height and weight, what sport you want to do, and the volume and complexity of the movements you're planning to do. And it will give you a metric based on the surgeon-defined laxity of your knee. So if your knee is lax, you get one set of outcomes. If your knee is less lax, then you get another. So you get some interesting data that you can share with patients in terms of decision-making. The next level up, which I'll come back to again later on because that's the direction of travel, is using machine learning with big data sets to try and predict that even better. The Moon data is interesting, but it's not the world's biggest data set. The registries have bigger data sets. Again, if those of you are interested, you can access it at this website or this QR code, and this gives you a slightly more sophisticated way of looking at failure risk over time. Again, here, failure is re-revision. This is a registry paper. Registries are obsessed with reoperations. It doesn't necessarily mean the patient has succeeded or failed. I'll share some data with you. So when I got asked to give this talk, we just finished this piece of work trying to identify patient and surgical factors that are associated with failure to achieve the minimum clinically important change in PROMs. So this is a patient-defined metric following ACL reconstruction at 2 years. So are the patients happy? Are they not happy? This is a registry, so it's retrospective, but it's got data from over 10 years. And the patients completed a number of scoring systems, as you'll see. There are in the literature defined metrics for what the minimum clinically important change is for any procedure. We can argue whether those are right or wrong, and different studies give different numbers, but they're interesting. And so we ran a multivariate stepwise logistic model to look at this. So this is 17,000 patients. If we go through it, they're more male than female. We know what sports they did. We know their BMI for what that's worth, and we know the time to surgery. We know their socio-demographic and fitness criteria. In the UK, you'll be pleased to hear we have 74% non-smokers. I sense that's not quite the same in France. And we have meniscal pathology in 60% and cartilage pathology in 25%. And I think that's worth considering because those things aren't necessarily factored in to the outcomes. These are the sort of procedures that are performed, so meniscal repair a lot of the time, but an equal number of meniscal resections, some with a senior surgeon, very few with the junior surgeons, and we are very autograft and hamstring heavy in the UK still. Admittedly, this is evolving as we go. Graft diameters are interesting. Majority are 8 millimeters or above, so we're not doing anything particularly crazy, and we're not, with very little all inside in the UK, 12.5%. So what are the factors that predict? If we look at coups, you're less likely to do well if you're male, if you're older, if you have a high BMI, and if you are a smoker from a low socioeconomic background that started with a poor activity level. If you look at in a more funneled way, then BMI, starting score or starting activity and deprivation become the important ones. And if we look at IKDC, just to look at it slightly differently, it's BMI, delayed to surgery, and preoperative functional level, and smoking. So we start to see a pattern in terms of what we can or cannot predict. The big caveat here is this is a registry. There is no fidelity about the intervention. It makes a huge difference where the tunnels are. It makes a huge difference how hard the graft is fixed. It makes a huge difference whether you add an extra articular tenodesis. That data is not necessarily always captured. So the reality is the technique will make a difference, and that's why ultimately if we can capture the real detail from a virtual reality platform and put it into this, that would be really exciting. But from our data right now, if you've got a higher BMI and you're less active, you will do less well. If you're from a lower socioeconomic class, you do less well. From our data, the surgical intricacy in how many menisci you repair or do chondral work doesn't seem to influence it. But that at least gives us a little bit of information in terms of both talking to patients, in terms of how we target the future. Moving forward, I think the real key will be using these data sets in a bigger and better way. The Norwegians have already done it, but does their AI model work across different data sets? We don't know yet. We're doing exactly the same thing with a slightly different black box with our data set, seeing if we can get a cleaner data set, a cleaner outcome from that point of view. But just to conclude, ACL reconstruction, unfortunately, even in your great hands, doesn't work for everybody. There is a failure rate, and that failure rate can be both subjective and objective, and that somehow eventually we need to feed into a shared decision-making model. And some of the factors that drive outcome are intrinsic, some will be injury-related, and some will be surgery-related, and those we can really make a difference to. But the future here really was exciting because we can use deeper data sets, more analysis, more AI, and work that out for our patients. Thank you very much.